Now, the recent death of best-selling author Chimamanda Ngozi Adichie's 21-month-old son has brought healthcare standards in Nigeria, Africa's most populous country, under fresh scrutiny, prompting calls for reform. The family of the Nigerian author has accused the hospital of gross medical negligence. Adichie's sister-in-law, Dr. Anthea Esegenwandu, a physician and professor with decades of experience, said she had been told that the young man had been administered an overdose of propofol to sedate him to conduct MRI tests. She argued that the anesthesiologist had been, and I quote, criminally negligent and had not followed proper medical protocol. Of course, we all know that all of these allegations still stand to be substantiated as we await official medical reports that can give us an autopsy report for us to know the true cause of death. Well, as we continue to look at how we can improve our healthcare in Nigeria, reduce anxiety often faced by people going for surgery and possibly intensive care, we're now being joined by Dr. Seyi Oyesola, an accomplished anaesthetist and medical practitioner with over 25 years on the cutting edge of practicing medicine. Good morning, Doctor, and welcome to the program today.
Good morning, and thank you for having me here. Well, Doctor, on this, we have had a public health expert.
Yes.
Professor Alero Roberts.
Correct.
We have had a lawyer who has handled many cases in the area of medical negligence, Dr. Lisa Agbakuba, SAN. And then on this program, you are the third person. And it's right down your alley. The introduction says you are an anaesthetist.
That is correct.
And it's one of your colleagues that is being said to have given an overdose of propofol. But the issue is about negligence. It's about protocol. Now, what would have been the standard protocol for administering anesthesia on a patient that is just about 21 months old? And where do you think something may have gone wrong?
Good. Thank you, and thank you very much for that question. Maybe we should just start from the beginning. From my perspective, it is not fair on the parents, the deceased, or for that matter, the professionals involved, for any of us here to start to comment on the standards that should exist or should have existed on this particular day. I would also like to state that prior to agreeing to come here, the agreement was that we would not be discussing the specifics of this case. I am happy to discuss anesthesia and critical care, in fact, because those are my specialties. I'm happy to discuss those topics generally. But I would not like to comment.
Reach the agreement with?
We reached the agreement.
Nobody tells us what to ask and what not to ask.
Do you see what I mean when I first arrived and I made that comment that you said? Because usually there is a brief. But my side of the brief was that I would not engage in conversation or discussion about the details specific to this case. And the reasons are obvious. It is unfair. It discourages public participation in an honest way. It often puts the whole investigation at risk if people like myself, who know what should obtain, begin to discuss that specific case without being there. If I was there, I wouldn't even be on this program. As you can imagine, it would be remiss. I would be remiss if I chose to come and speak about it. But I'm very happy to talk about anesthesia and critical care. I'm very happy to create a level of awareness, which I think is missing. A great deal of that is missing where the public, even among our colleagues, what is anesthesia? What do these people actually do? If you ask the general person who knows a little bit about it, they will tell you, oh, yes, of course, they put people to sleep, which is true. But the truth of the matter is that if it was just sleep, then when the surgeon comes with his knife, you will wake up. So there's an element of pain relief that is involved. In order for you not to move and the accuracy of surgery can take place safely, it is also important that you are stopped from having reflex movements. So that sort of summarizes what anesthesia is all about. Now, with modern medicine, and this brings me to what you are probably interested in hearing, with modern medicine, it is absolutely essential to recall that a lot of the successes that medicine has to be proud of these days, a lot of the positive outcomes that people record from going abroad, and this is a very important point I don't want anybody to miss, is because anesthesia and critical care have served as a fantastic basket to rescue people who are sick. Now, the sicker you are, the more likely you are to go to intensive care. But the truth of the matter is there are even some routine operations, for example, open heart surgery, which I've been fortunate to be very much a part of initiating, starting, and maintaining in this country from the anesthetic point of view. You cannot do that you can't even take such a patient to theater without having a critical care unit ready and waiting. And when I say a critical care unit, I'm not talking about the building. I'm not talking about the equipment. I'm talking about the staffing. That we are not talking about somebody who read it in a book, somebody who has done several. That person is now qualified to support the surgery, or for that matter, and just one more point. Anesthesia and critical care covers every single specialty in medicine. From psychiatry to obs and gynae, to pediatrics, to surgery, even just plain medicine, physique, as we call it. It covers all of them, because it's when those people have not been able to do the outpatient, inpatient, then they call the intensivist. They call the anaesthetist. This one is getting bad. And I'm sure Professor Roberts has explained some of that too.
In fact, I'd like for you to sort of expand on a few things she said. You know, specifically she said that, well, anesthesia on its own, of course, when administered in the right circumstances with the right level of monitoring and all protocols observed, is safe.
Yes.
But she also said that there's no anaesthetist who hasn't lost a patient before.
This is true.
Can you expand on that? Because we want to understand at what point does it become a risk? Okay. At what point should I be scared? Because the general consensus is that, anything that makes me pass out, please, give me general anesthesia. I don't want to be knocked out.
That's the same thing. General anesthesia means you'll be knocked out.
No,
that's what it means.
give me local anesthetic.
Give me local or regional.
Give me local, yes.
So that
I don't want
only
to be
a part of my body is deadened.
Yes.
I don't want to lose consciousness.
Yes.
You're absolutely
which is what most
right.
of us ask for, yes.
So where does one start? Now, every medical procedure, whether it be anesthesia or somebody removing your toenail or just a circumcision, every medical procedure is risky. And that is why before you engage a patient, or for that matter, anybody in medical interventions, your duty is to obtain informed consent. So when does it become risky? As soon as you submit yourself to surgery. Let's say you are not particularly, it's elective. This is something that can be left till next week. Then it's straightforward. I have to sit down with you, tell you in clear terms what I'm going to do. I have to tell you the consequences of not doing anything. And then I have to tell you at least the common complications, which may include death. So, does that answer your question, or do I need to? No,
I want to know how when I walk into a Nigerian healthcare facility, how high is the risk of my getting the extreme, which is death,
yes,
from being administered under anesthesia?
Anesthetic. Okay. So there's always risk to every procedure, including anesthesia. All right? Now, let me illustrate this point, because I chose to go into anesthesia and critical care because I accepted the risk, but I also know that the risk has been significantly mitigated by the modern developments.
In Nigeria?
In Nigeria and all over the world. For example, when I was still training and a junior doctor, the malpractice insurance premium, which is a measure of risk, the malpractice insurance premium, not here, in the US, in the UK, the premium anesthetists used to pay was one of the highest, showing that, this is a risky specialty. By the time I qualified and I started to learn anesthesia and critical care, we discovered that we now have the lowest insurance premium. In other words, the risk has become so low that we know for a fact that if you go into surgery now, you are more likely to die crossing the road than having an anesthetic. Now let's take that even a little bit further. Why? Why has the risk been reduced so greatly? Why is anesthesia safe? Why would a surgeon subject their patient to anesthesia, knowing jolly well that the definitive treatment has to do with a scalpel and some sewing? It's because it is relatively safe. And the reason is this: monitoring. It's been mentioned before. There are 5 basic monitors that you must use on every patient. Their heart rate, their ECG, their pulse oximetry, their blood pressure, and something else we call echocardiogram, capnography. Okay. Yeah. So that's why it is safe.
Monitoring.
Much safer than it used to be.
Okay. As a doctor that administers anesthesia,
yes,
who do you report to? Who regulates you?
We have our own body. For instance, in Nigeria,
what's it called?
It's the Nigeria Society of Anesthetists.
Who regulates the Nigeria Society of Anesthetists?
The same society or the same body that regulates all doctors. The Medical and Defense, Medical and Dental Council of Nigeria, MDCN.
So the Nigeria Society of Anesthetists, they set guidelines,
yes,
and regulations of how anesthetics will practice.
Yes.
And they also have guidelines
yes.
for monitoring.
And they're also responsible for training.
Yes. So they're also responsible for training, and they have guidelines for monitoring on how the anesthetic. Do you, as an anesthetist, file a log of the guidelines deployed for every case file?
Okay, and that's an excellent question. It's a legal requirement.
So you have a log?
It is a legal requirement. It's called an anesthesia record chart that starts before the anesthesia is actually administered. You actually have to go and do a preoperative evaluation. You need to establish the age, the sex, all the usual demographics. Now, it doesn't matter what the patient is coming for. What if the patient is diabetic? What if the patient is hypertensive, epileptic, asthmatic? People have all those conditions and they are coming for surgery or they are coming to be treated for something else. So as part of our training, and all anesthetists around the world have the same training.
So for every procedure,
every single procedure, it's documented.
We have to file that chart. So after every procedure, a patient can ask the anesthetist for that chart, right?
The patient can. It is their property, actually.
Their property.
Yes,
Thank you very much. Thank you.
All right. Unfortunately, that's all we have time for, but certainly an enlightening conversation. And, well, I'm not sure if it's going to tamper down anybody's anxiety or about going under the knife or, being knocked unconscious. But it's a work in progress, certainly.
It's a work in progress.
Thank you.